The role of radiosurgery in obsessive compulsive disorders. We cannot speak about the radiosurgery in OCD without referring to Jean Talleyrand. Jean Talleyrand was a French neurosurgeon at the time of prefrontal leucotomy. He was understanding the need for more focal and precise approach. And thanks to his knowledge of the anatomy, he understood instead of cutting largely the frontal fibers, you can obtain the same functional and clinical result by a much smaller destructive effect in between the head of the caudate and the striatum at the level of the area we call the anterior limb of the internal capsule, the halic. But this was requiring the creation of something new, which was stereotaxis. Just taking off at this time, he was thus the one introducing the stereotactic anterior capsulotomy. Talleyrand was a very interesting character, trained as a psychiatrist, resistant, and he turned out to be the great leader of the functional neurosurgery and the founder, in a way, of the functional neurosurgery in France with Guyot. I got the chance to meet Jean Talleyrand and to work with him on my science work about the gyration of the cortex, and that was very founding moments in my professional life. The very beginning of the work of Lexel in stereotactic radiosurgery, the first published patients were treated actually with protons in Uppsala. And when you read the very first paper reporting the very first patient was treated in the age of 56 in 1958, and he got an anterior capsulotomy for depression. So the very first radiosurgery ever published was anterior capsulotomy for depression, the surgery developed by Jean Talleyrand. The beginning of the use of this surgical strategy, both as a target and as a technique of radiosurgery, started in the 50s. In 1953, the first treatment of psychiatric disease was performed with the prototype of the Gammaknife. In 55, the pioneer team published a series of 7 patients with OCD, all treated by radiosurgery at the level of the anterior limb of the internal capsule. And they were reporting a long-term benefit in these patients. For those who are interested to know more about the literature, we published some years ago a summary, the review of the literature, and you will find all the relevant papers about anterior capsulotomy with the Gammaknife. Interestingly, in Stockholm, for some reason, the practice of radiosurgery for anterior capsulotomy turned short. Actually, technical changes have led to a series of complications, and nowadays the use of the radiosurgery for anterior capsulotomy is more or less banned based on this bad experience locally. But the paper from Lars Rydström is showing very nicely the reason why this patient got complications which were related to technical changes, to mistakes, I would say, seen from today. Interestingly, in US, in Rhode Island, there is a very famous institution in terms of psychiatry and OCD treatment. This is Brown. This is the institution creating the Y box, the Yale Brown Obsessive Compulsive score. And then that's also the place where George Norrie and Christopher Lindquist went, where then they left Stockholm. So by chance, these two expertise were together, and they started to perform anterior capsulotomy with the Gammaknife in very well selected and evaluated patients. But with the experience of the few toxicities in Stockholm, the Swedish were very cautious, and George Noren performed a first series of patients treated only with one shot in the anterior lip of the internal capsule, because he was a very cautious person with the bad memory of the complication in Stockholm. And this first group of patients, we call it here group 1A, turned out to be poorly responding to radiosurgery. You see that was one shot on each side with 180 gray. Only 7% of the patients got more than 35% improvement of the Y box. That was some kind of disappointment in these 15 patients. Then they decided to propose to complete this radiosurgery with a second shot. 13 of the 15 patients accepted to be treated with a second shot, and George Noren performed this second radiosurgery, and interestingly, the results turned out to be much better. At the end, among these 13 patients, 8, which means 62% of these patients, got more than 35% improvements of the Y box at 3 years. Interestingly, you see that the results are improving over time. The results are already starting to be good at 1 year, much better at 2 years, and even better at 3 years. This is the same thing for all the technique, including DBS. And that's extremely important to keep in mind, that there is a delay, and these techniques must be evaluated with a minimum delay of 2-3 years. So based on this experience, the group in brown started to be more confident and to treat some patients immediately with 2 shots and a dose of 180 gray. And globally, in a group of 37 patients, 26, which means 70% of the patients, have turned out to have more than 35% improvement at the Y box, which is very good result, competing with all the other surgical technique very well. The technique as practiced by George Noren, you can see here on these Gautier images, you see his target was quite anterior compared to the anterior commissure. You see this is in between the head of the caudate and the striatum. You see this is quite low, close to the nucleus accumbens. I'm pointing these details because gradually the technique have slightly changed. So that was the target as described by George. That was 8-10 millimeter anterior to the anterior commissure, and that was still 2 4 millimeter collimator on each side, one ventral to the other. So this is the targeting with the 50% isotose line. And they were using plug patterns to make the shots conformal to the internal capsule. So the result globally in 55 patients at the first follow-up at 12 months, that was 61% responding partially or fully responding, 45% fully responding, but at 60 months, that was turning out to be 78% responding, with 60% being full responders. So very good results. The adverse events were modest. The majority of these adverse events were transient, with sedation, fatigue, anxiety, agitation, loss of interest, difficulty of concentration, inattention. All these were transient neurological side effects. One patient have reported amotivation, loss of drive. For a very long period of time, they got no, I would say, anatomical complication. And then at the end of their experience, they got 3 brain cysts, which were a little bit scaring for the team. You see here one of these patients, and this is another patient with a larger cyst, with IT2 sign all around, 5 years after the Gammaknife ventral capsulotomy. And the occurrence of these cysts was at the time of the change of the machine they were using in Brown. They were using for a long while the U type of Gammaknife, and they have changed for the C type when they found this free cyst for the first time after a lot of patients treated without complications. I got the chance to discuss with Rhys Cosgrove when he was taking over in Brown, and he was facing these free complications, and my recommendation was not to consider that Gammaknife radiosurgery with the Model C was dangerous, but that maybe the adaptation to the special dose distribution of the Model C was not correctly done in terms of transition, and maybe a good physicist can help. So I recommended him to discuss with Jan Paddick, and Jan Paddick have done a very great work on this data, and he demonstrated how the different dose distribution between the U machine and the C machine was leading to deliver actually more dose to the brain with the C machine. You see that for certain level of dose, especially the low level of dose, like 30 or 40 gray, you see that the volume receiving this dose with the Module C was much higher. And this was based not only on the Brown experience, but also on a number of other centers around the world. So Jan Paddick very nicely have compiled all this data. You see here different graph where you see the representation of the volume receiving a certain amount of dose. Here you see the volume, and here you see the dose, and here you see the prescription. Of course, centers prescribing higher dose were having more rapidly more dose to larger volume. Here you see 120 gray, which is the dose we are prescribing in Marseille and in Madrid, based on the experience of Roberto Martinez, who was the first to propose this escalation of dose. But please pay attention to one thing, which is the line 120 is higher than the line 160. But this is related to the short spacing. So what I've shown very nicely, Jan Paddick, is that depending on how you created longer or shorter distance in between the shots, you are actually delivering more or less dose. At the extreme, if you put the two shots at the same place with the same prescription, you will have a very minimal dose volume distribution. The more you create a longer distance, the more actually you are over-treating in terms of low dose received to a larger amount of brain. And that was really the explanation of the bad effects observed at the end of their experience in Brown. That's another demonstration of the role of the short spacing, and you can see here that when you use 120 gray and you space the shot 4.55 millimeter, here you are having really an effect in terms of beam on time and dose to the brain, which is much lower and corresponding to a lower risk. This took long years before having published the experience in Rhode Island. And this is the paper. This is a very important paper, certainly the best paper ever published on anterior capsulotomy with the Gammaknife. I recommend you to read this paper. And this paper is actually showing the very good results of radiosurgery on both the obsession and compulsion and anxiety of these patients. There is in the literature a lot of experience with RF, thermocoagulation of the halic, of the anterior limb of the internal capsule. And there is also an experience of the deep brain stimulation of the same structure. But the paper from Pepper, who was working at this time with Marwan Ariz and Ludwig Zrinzo, is a very interesting paper because this literature review is showing that actually when you are comparing the papers with capsulotomy, whatever it is, RF or radiosurgery, to the one with the DBS, you see that actually the percentage of patients not responding is much smaller. The percentage of patients with excellent result is much larger when you do an anterior capsulotomy compared to what you obtain with the brain stimulation. And I think that all the published papers since this review of the literature are confirming this finding. There is, interestingly, one prospective paper evaluating the effect of Gammaknife capsulotomy comparatively to sham. That's a very nice paper, and that's a paper demonstrating very nicely that there is a very objective effect of radiosurgery on the symptoms of the OCD. That's a paper with a high level of evidence. However, one of the patients have turned out to be mis-evaluated, which led to the retraction of this paper. According to the first author of this paper, this is not changing at all the conclusion of the paper, but this is leaving a little bit of shadow on the value of this paper. There is a number of papers published nowadays, and when you look at the modern results of these papers, you have to pay attention to the technique. You have to look at the papers which are quite recent with technique at the state of the art, and you will see that the results are very coherent. Roberto Martinez is having in Madrid a huge experience of psychiatric surgery, one of the largest in the world, and he is not dogmatically aligned on one technique. He's doing radiofrequency, he's doing radiosurgery in these patients, and he was the one proposing to decrease the prescription dose from 180 to 120 gray. And he published with Giorgio Spatola when he was in my group, and with our group, we published together his 10 consecutive patients treated this way. And this paper is demonstrating with a technique very close to the one from George Noren, with two shots which are a little bit less close to the nucleus accumbens, which are a little bit more posterior at the limit of the posterior wall of the striatum, as you can see here. So that's slightly different from the technique from George Noren, with two shots, sometimes helped by the tractography, at least by the FA of the DTI. And this group of patients have turned out to be very successfully treated. You see that there is 70% responders, with 50% of the patient being in remission and 20% recovered. We have 10% of partial responders, and we have 20% of failures. So these results are really at the top of what you can find when you look at all the different techniques published in the literature. You see here the result with all the patients one by one. You see that there is one patient improving and recurring, but rapidly. You see the effect on obsession and compulsion, the effect on the back, on the depression. You see the effect on the anxiety, on the GAF, and on the clinical global impression, and on the quality of life with the Euro QOL. All these parameters are dramatically improved in the majority of these patients. These are the effects of the radiosurgery at 24 months. That's a typical effect, which is showing well the orientation of the two shots on this image. And this is the same thing on the axial view. And you see the effect of the shots on the axial, on the coronal, and the sagittal view in this patient. So when we compared our results to the one from the literature, you see that all the series are quite modest series in terms of numbers, but you see that in spite of the use of much lower dosage compared to the others, the result in terms of efficacy are not altered by this decrease of dose, which is extremely important information. In terms of toxicity, side effects, the worst in the literature is the paper from Ruck in Stockholm. Our series, we have only one patient with a loss of interest, one patient with a weight gain, and a subjective memory change, which was not confirmed by the objective assessment in one patient. So this is turning out to be very safe. So the conclusion of this paper we published some years ago was that the capsulotomy with the Gammaknife is very promising, can be very safe for severe OCD cases. And we are now treating all our patients with this small dose of 120 gray, which is turning out really to be very as effective and much safer. More and more we tend to use tractography to improve the targeting. So interestingly, historically, a number of different strategies have been proposed. Some authors have tried to target with a single shot very low at the level of the nucleus accumbens. Some others have tried with one shot at the midpoint of the anterior capsule. Some others have tried to, like George Regis, to put 2 shots in second series of patients. More recently, some of us have tried with more shots with the aim to better control the low dose. But today, the consensus is more to have 2 shots in the middle part of the halic. So the challenge for today is to know what are the fiber binders we do need to target and how to target precisely, accurately, individually these fiber bundles. There is a number of work in literature. There is a series from Samir Shet, which is a very interesting series where they found that there is a significant variability in lesion volume with the same planning, and that the lower radiation dose and smaller lesions were producing fewer adverse events in their experience. What they found was better outcome was in writing in this paper. Better outcome was associated with lesion in the more dorsal aspect of the targeted region. But when you look at this paper, actually these offers are not that dorsal. So my interpretation of this paper is that this is confirming that we have to be in the mid part of the halic, not really in the dorsal part. You can see very well here that they have never been actually in the dorsal part. So they are less dorsal, but they are in the mid halic. So there is a lot of papers. I don't have time to enter in the details, but certainly in the future, what we need to know is to individually locate what are the fibers we need to disconnect and individually identify and localize these fibers in order to be more limited in terms of action with a better safety efficacy ratio thanks to this more precise targeting. And there is interesting papers which are really confirming in a way the paper from Samir Shet, which is that the target is not the more ventral part, it's not the more dorsal part, but the target with the connectivity corresponding to the anterior cingulate and the orbitofrontal cortex is really corresponding to the mid parts of the halic. Georgios Patela, based on our material, have done a very interesting work in this domain. He looked at the correlation between the size of the lesion and the Y-box, and he looked at the fiber density reduction and the correlation to the Y-box reduction in a series of 7 consecutive patients. That was his PhD. And he found that fiber interruption in FDC in the lower leak of the non-dominant hemisphere was the stronger predictor of a higher Y-box reduction. But again, this is what we call dorsal, is not is more the mid iliac. There is also an experience with LIT, interstitial laser anterior capsulotomy, with very similar findings in terms of correlation between the topography and the outcome of the patient. So the experience of our material, based on our material, is that with minimum dose of 120 K, we are very effective. The fiber density reduction is independent from the lesion size, so we don't need to have a big lesion to be efficient. The fiber interruption in fiber density and bundle cross-section in lower iliac of non-dominant hemisphere is predictive of higher Y-box reduction. The Gammaknife is inducing fiber reduction in the fiber bundle and bundle cross-section in the SLF of our successfully treated patients. Interestingly, we treated a patient who was having both very severe OCD and a Tourette. This patient was quite effectively treated by a thalamic stimulation for her Tourette, but she got a number of surgery for OCD, several DBS failing systematically. She was actually asking for suicidal ending, and she was proposed radiosurgery. We performed anterior capsulotomy. We got a fantastic result with a complete response. And what is interesting, and the reason why we have published individually this patient, is because these patients have completely stopped to have Tourette. So we were able to stop the stimulation of the thalamus after several months when the clinical symptoms of the OCD were gone. Interestingly, that was difficult for the patient to withdraw this therapy. When we were stopping the stimulation of the thalamus, she was not having a recurrence of the Tourette symptoms, but she was having some kind of anxiety. She was in need. She was addicted to the DBS, and she progressively stopped the stimulation, and now she was completely free of stimulation, but this took several years. So in some patients with Tourette, maybe anterior capsulotomy can be an option. Interestingly, there is still a lot of debate about what are the best targets. My friend Stéphane Chabardès in Grenoble is a great advocate of the STN in OCD patients. We know that Bart Nutin, who was the first to publish DBS in psychiatry, is coming also with the bed nucleus target. Rick Sherman is an advocate of the ALIC, and I must say that we are following Rick in this group of patients. So as a conclusion, I will say that the Gammaknife capsulotomy is significantly improving symptoms of the OCD in at least 2 on 3 of the patients, 75% remission at 2 years, which is very high. The improvement is demonstrated to be sustained and is continuing to improve over time. The Gammaknife capsulotomy is relatively a safe procedure with only transient neurological complication in the modern series of the state of the art. Capsulotomy have been evaluated in patients with OCD associated with Gilles de la Tourette and anorexia nervosa, with also in anorexia nervosa, like in Gilles de la Tourette, and a good effect. But these were patients who were having both diseases, and the efficacy was good both on the OCD and on the Gilles de la Tourette and anorexia nervosa, which is interesting, especially because in anorexia nervosa, frequently the trophic aspect, the body weight, are just a contraindication for the DBS, and the dysmorphophobic problem of the patient are also frequently an obstacle, in my experience, to the DBS. There is a very large experience with RF lesioning, although there is few papers, and we must keep in mind that we can do something very similar just with RF, which is very cheap, and there is a lot of places around the world where DBS is not an option, where Gammaknife is not even an option because of cost issue. And I think this would be wrong to say that the only two ways to go are either Gammaknife or LIT or DBS. There is a cheap and effective solution, which is RF lesioning of the hallux. SRS with the Gammaknife is having a completely different mechanism of action compared to thermocoagulation, and that's something we have to keep in mind when we are thinking about role sorting in between the techniques. There is one level 1 trial demonstrating Gammaknife surgery capsulotomy efficacy. Radiosurgery of the hallux is really, in my opinion, underutilized. DBS is the queen in a number of diseases. I think for Parkinson today there is nothing better than STN DBS. But I'm very convinced by my experience that in OCD, hallux radiosurgery is really a great option, and certainly a superior option compared to the DBS for a lot of patients. Of course, psychiatry is a difficult field where we have to be especially cautious. I recommend everybody to read cautiously guidelines. There is a number of guidelines which are available in literature now. This is requiring absolutely multidisciplinarity. You need to work with psychiatrists which are really specialized, and we need several psychiatrists providing with their opinion. We have to be very cautious in terms of information, in terms of follow-up, in terms of taking the time to proceed with the patient. In the very special field of psychiatry, it has not been shown that DBS is better than lesioning procedure. I would say that we are closer to the opposite conclusion. DBS is definitively a crucial approach for new targets and indication refinement because of the reversibility, and certainly there is necessity to keep continuing to propose both to our patients. Thank you very much, and attend the ESSFN courses and congresses upcoming. Thank you.